Dear friends, dear colleagues, good evening from Hong Kong, and thank you for joining this session. Also, many thanks to Straumann Live for making this virtual session possible. As we move on, time to get going, and the counter, as I see, has already hit 0. When I first saw this poster, I found very interesting the photo that Straumann Live chose to promote this session. Two guys setting up a tent on a beautiful beach. It couldn't be more appropriate for actually what I wanted to do. And essentially, I got with a very tempting idea to run this live session from some nice beach of a free camping area in Hong Kong. You might not know that Hong Kong actually has a lot of nature, much of it really intact and available for free camping. Unfortunately, I was very quickly disciplined by the organizers, and I was instructed to always stay under a fast line. So we won't be broadcasting tonight from this beautiful beach of the northern areas of Hong Kong. Nevertheless, I would like just to share with you some of this beautiful scenery. It would take you approximately 4 hours of hiking to get there, and then you can set your tent in the late afternoon, have a beautiful night's sleep, and possibly wake up around 6:30 in the morning from a burning sun or from the tide coming close to your tent, and then you realize, oh, I wish I had selected a little bit different position to set up my tent. Now, sometimes I think we face the same situation with implants. We have a lot of options. We place implants which very easily and predictably also integrate. We restore them one way or the other, and then after a while there comes a time when a problem occurs, and then suddenly we realize, oh, I wish I had placed this implant a little bit differently. Now, when problems occur in the long term with dental implants, there are some interesting characteristics that we came across some years ago when we were investigating long-term complications. We find a lot of things that we expected, percentages of screw loosening, percentages of perimplantitis, and so on. But there were some things that surprised me. First thing was that the complications appear to be clustered. Now that means that few people get most of the problem. If I say 30% of prevalence of screw loosening in this population, it doesn't mean that 30 people out of 100 will get one screw loose. It usually means that maybe less than 10 people will have more than one incidences of screw loosening, and eventually they will be the unlucky ones. But it not is really something that has to do with luck. Another observation we had was that there is a very close interrelation of what we call biological and what we call technical problems. So sometimes people with a screw loose might be much more likely to also have perimplantitis. Now, this doesn't mean that a screw loose will cause perimplantitis, but it points to the fact that many problems and many complications of the long term, they have common origins. They come from the same design flow or from the same area. If you look at it a little bit closer, you will come across with the realization that much of our long-term registered problems with implants, they originate from a very narrow, small space, from the space defined from the crestal bone on the apical side to the soft tissue margin on the coronal side and everything that exists in between there. What starts there? Well, all the plaque-induced inflammation diseases, mucositis and perimplantitis starts there. Also, recession starts there. And sometimes there is the manifestation of changes of the bone or the soft tissues due to some post-surgical alterations like causing dehiscencies and so on. From the technical side, this is where we have the screws, the abutment screws, the prosthetic screw, and the loosenings or fractures of these screws. This is where we have also implant fractures or abutment fractures on the implant coronal side. And in a very recent study, we came across the realization that some of the veneer problems and the chipping that we observe on the veneering might have its origin into some misfit or some tension that is locked into exactly this spot where the abutment and the implant and the prosthesis are held together. So how do we approach this spot? How do we define what happens there. One of the most interesting features of this place is that we have a very tight cohabitation of human tissues interacting with mechanical components and with bacteria. And all this together striking a balance or failing to strike this balance. So sometimes I think we need a new paradigm to approach this area. And our paradigms are not always possible through science. Sometimes it's much more inspiring to look into other directions like science fiction. And here are some of very well-known science fiction characters, cyborgs from the western side of the world. My favorite ones are actually the ones that come from Japan. They're much more complex personalities, they talk more and they shoot less. Now, what we have here is a man-machine system. It's human tissues together with machine working together for the same purpose. And this might sound like science fiction, but it doesn't really come from science fiction. The term cyborg, you might not know, comes actually from science. There are these two guys, Kleins and Klein, scientists in NASA in the 60s, who published this paper where they make a visionary statement of how humans in the future will be able to incorporate mechanical components into their bodies in order to enhance performance, to rehabilitate, or to adjust to environment. So the cyborg is a man-machine system that incorporates exogenous components functioning as an integrated, self-regulated homeostatic system. It is an organ that is composed of machine and human working together. Now, could you find any better definition for an implant rehabilitation therapy in the 21st century? And I think that's what I would like to do every time I am designing a prosthesis supported by implants. So this tiny little space that we described before, which I would describe as the supracrestal complex, is our cyborg, is the area that we decide and we define success or failure in the long term by establishing the conditions for human tissues, bacteria, and mechanical components to strike this beautiful balance we're after. I visualize it as a cohabitation of many different parts, many different strangers, like we share the same building. And in the ground floor of the building, the foundation also is a bone in very tight contact with the implant, osseointegration. Inside we have an abutment screw, and all this into a specific configuration that we call a connection, and in this case is an internal connection. Now, what is important is that something that goes wrong with the screw might actually has its first manifestation with a problem on the bone and vice versa. And this is this tight interrelation. On the first floor, we have the connective tissue. Here we don't have integration, we have adhesion, a much looser coexistence with the implant abutment. And on top of that, we have the junctional epithelium, which is a true attachment where the cells are actually truly attached on the abutment or implant surfaces. And on top of that, we have the sulcus. The sulcus being a slot, being a tight contact, but not really adhesion, neither attachment, with crevicular fluid, sulcus fluid flowing in there out into the mouth. And of course, we have a prosthesis in the equation, access groove channels, and we have the roof on top of the sulcus, which is full of life because this is where bacteria live, proliferate, and the biofilm is being established. Now, all this also might have some uninvited guests sometimes. We might have cement rests in this supracrestal complex, or we might have some biomaterial particles emerging through the soft tissues when augmentation procedures have taken place, and these particles are trapped into the soft tissues rather than being part of the bone. And why I do like this cohabitation analogy is because it is very, very clear how one depends on another and how problem in one spot can actually create trouble to the other. So if you have a very noisy neighbor on the rooftop, then we might have other people being really angry, complaining, or causing even trouble that in the future might force someone to move out of our cohabitation. And this is actually how do we perceive health and disease today. Because 200 years ago, when bacterial cause of the disease was documented, there was a paradigm of bacteria causing disease. Eliminating bacteria might bring you back to health. Today, especially when it comes to chronic inflammation, the paradigm is changing. We see that bacteria is part of the equation, and it is not a matter of eliminating bacteria, but it's mainly a matter of striking a balance, which is a symbiosis, is a positive cohabitation where everyone respects the rules and lives happily together, and preventing the dysbiosis, which is like losing this balance and having this cohabitation going bad. Now, our supracrestal complex and our chance to establish this cohabitation on a positive sign is to apply the best principles we have in order to create an environment where the tissues and the bacteria, together with the mechanical components, will strike this favorable balance in the long term. What could be the design features that are emerging as important when we design the supracrestal complex? Quite a lot. We have choice of material, and material interaction with bacteria and with human tissues is a very, very quickly emerging area that we can definitely learn a lot in the future. From the macroscopic features, we also have the cervical margin. The cervical margin is the margin of the soft tissues, and this is defined also by the aesthetics, the circumferential margin where the prosthesis first meets the soft tissues. We also have the emergence profile, which is the way that the transition takes place from the bone crest all the way to the cervical margin. So how will we make this transition from a narrow implant on the bone crest all the way up to a wide prosthesis which meets the soft tissues? This is the emergence profile. And we also have a lot of interfaces. We have some junctions that are very critical. The interface between the implant and the abutment, and also the interface between the abutment and the prosthesis in different configurations. Now, how tight, how reliable, how close and how stable these interfaces are, this might have a very significant impact on our supracrestal complex design. And of course, that leads also to the component fit, how these components are made to fit together, in what configuration, how tight, and would this actually promote stability or include some problems. Now, cements and different biomaterials that are used in order to design this supracrestal complex might also be part of the equation. Today, I will focus on some of the macroscopic features that we can influence when we're designing the supracrestal complex, and within the scope of this presentation, I will discuss a little bit the important parts of the cervical margin, emergence profile, and also the transitions, the interfaces between the different components. So, when we have a natural tooth, we have a natural scalloping occurring of the soft tissues, which is because of the support of the scalloping that exists also in the bone and the scalloping that is followed by the cemento-enamel junction. So it's a multifactorial feature. Now, if we are placing an implant in the bone level, there will be a transition, the transition zone that we described before as the emergence profile. And this emergence profile will be surrounded by the soft tissues, as we described before. Now, one of the first questions that occurred also very early in implant dentistry was, how much height do you need of the soft tissues in order to accommodate a sustainable emergence profile? And the very first studies that investigated these vertical dimensions were, of course, conducted on animals. So what type of animals? Pretty much very different species. We can have from monkey to different types of dogs, all the way to mini pigs. And that was histological and histomorphometry sessions, which try to identify the dimensions of the soft tissues. And of course, as one would anticipate, there is a very big diversity, not only on the total, but also on the individual components, junctional epithelium, connective tissue, and so on, depending on the animal species. So although that animal studies can give us a very good understanding of the structures which might relate to the human equivalent, it is very difficult to extrapolate actual numbers for actual dimensions from the animal studies. Of course, then there would be also a handful of human histological studies that have tried to address this particular question as well. And here you will also see significant diversity. Although this is all 3 studies that are done on human histology, you see the connective tissue zone on the vertical dimension might differ from 0.7 millimeters to 2.5 millimeters and so on. So many people try to identify the exact dimensions and they see who is right, who is wrong, what is the true dimensions of the vertical sizes of these components. Well, I think everyone is true. We have to understand also that many of these studies are done in different configurations and different setup. For example, here, the first two studies are done with very specifically designed implants, mini implants or devices, which are not really the true implants that we place and restore in the mouth. Only the third one that you see here at the bottom is actually a histology, a human autopsy from implants that were placed and restored exactly the same way we do with our daily practice. But another important parameter here is that there is not really a mathematical problem. This is not a problem of arithmetics with one right answer. This is actually a biological feature. And as all biological features, it is expected to be significant variation between different humans or between different sites in the maxilla and mandible, or even between different sites, buccal, palatal, or lingual of the same peri-implant tissues. So we have to accept the variation as such, and I think if we take away the outliers, we might end up with the majority of these measurements coming to suggest that a height of about 2.5 to 4 millimeters is essential for the establishment of these vertical dimensions of the peri-implant tissues in humans. So when it comes to the vertical dimensions of the peri-implant tissues, we have an attachment and adhesion zone, junctional epithelium and connective tissue, which would require around 3 to 4 millimeters, and on top of that we have a sulcus. Now, the connective tissue and junctional epithelium appear to be formed by genetics. There is not much we can do to predictably change this zone. When it comes to the sulcus, however, there is very little described in the histology and very big diversity in what they have found. And why is that? Because sulcus doesn't seem to be determined by genetics. Sulcus is something that is determined mainly by the local anatomy and the configuration of our implant abutment prosthesis in the tissues. So essentially we will have the attachment and adhesion on the first 2 to 3 millimeters, and then whatever is on top is going to be sulcus, with sulcular epithelium in close proximity to our abutment or prosthesis, but not really adhering or attached to it in any way. And today, if we actually see all the placement in the aesthetic zone where we try to recreate the scalloping of the soft tissues, there is no other alternative other than creating a very deep sulcus around our implant prosthesis, because of course the zone of attachment and the adhesion cannot be manipulated. This can also happen with tissue level implants in the posterior when we have, for example, higher level of soft tissues, as it occurs maybe towards the tuberosity of the maxilla. Again, the attachment zone will be established as always, and whatever comes on top is going to be sulcus. So the scalloping that we see in the aesthetic zone of the soft tissues is because of the scalloping of the underlying bone, which corresponds to also the scalloping of the cemento-enamel junction of the teeth. Now, whether we use tissue level or bone level implants, we cannot replace this scalloping, we cannot recreate it. The biologic zone is going to be established in the same way, and once we create the emergence profile, we will have a deep sulcus in the mesial and distal of our implant prosthesis, corresponding exactly to the areas of the papilla. That means that if you're going to use the floss in order to reach the first point of resistance, the junctional epithelium around natural teeth, you would probably not be able to go deeper than 1.5 millimeter. If you want to reach the same point, the junctional epithelium around implants, then the floss will have to go much deeper, because we do have a deep sulcus in this site. But is it essential, is it necessary to actually need to clean that much? So what we have in a deep sulcus configuration? At the bottom of this sulcus, I would expect to have the attachment of the junctional epithelium and the adhesion of the connective tissue established. Now, the rest from this point all the way to the cervical margin is just a sulcus with a sulcular epithelium. Of course, this is in an environment which is full of bacteria. Bacteria live in the mouth. They have been there forever, and actually they should be there because bacteria contribute to your health as much as your own cells. So it is not the bacteria that is a problem. But would this deep sulcus be an area of problem in a septic environment? Here we have to also understand how inflammation initiates on the peri-implant tissues. And the inflammation is not started by individual bacteria in a planktonic state swimming into the depths of the sulcus. Apparently, the inflammation will always be related to the biofilm. And the biofilm needs two different conditions in order to accumulate. Needs a hard, solid surface and a liquid environment. And this is the prosthesis. So the biofilm is going to accumulate on the prosthesis first. And the area where the biofilm will interact with the soft tissues first is not the bottom of the sulcus, it's actually the top of the sulcus, is the cervical margin, is where the soft tissues meet the prosthesis. So if you allow the prosthesis to accumulate biofilm, then you will soon have inflammation as a response from the soft tissue margins. And this is very well evident. We have half a dozen of studies of experimental mucositis which actually prove that in all cases when you allow plaque to accumulate and mature on the prosthesis, within 3 weeks in all cases you will have establishment of mucositis, of inflammation. And this is actually something that you can also reverse. So by removing this biofilm, by destroying the accumulation of pathogenic plaque onto the prosthesis, you can help the tissues re-establish their health. So if you see a sulcus that looks like that, full of inflammation, then you know that you have a problem. But the problem is not in the sulcus. You cannot see it in the picture. The problem is actually in the crown. And the crown, corresponding to the sulcus, you can see immediately what the problem is. The problem is biofilm. And biofilm accumulates not overnight, but it will take a significant amount of time, 2 to 3 weeks, until you will have the inflammatory response. On the other hand, if you create a crown that is cleanable, and if you teach your patients to remove the biofilm on a daily basis, it will never mature to become to this stage that will provoke inflammation. So a cleanable and clean crown will be corresponding to a healthy sulcus for the long term, regardless if the sulcus is actually deep or shallow. So what we can do in order to maintain our implants on the long term into a healthy status is two important parameters today. It's designing the cervical margin in a way that it is cleanable and it's accessible throughout to oral hygiene. And that means that the cervical margin coincides with the opening of the sulcus, and also try to make this transition from the implant to the cervical margin as favorable as possible by designing an emergence profile that is favorable to our balance. Now, what could be a typical problem that we see that predisposes to inflammation is when the cervical margin does not really coincide with the opening of the sulcus, and this is a typical ridge lap. This is when the cervical margin is actually horizontally projected far away from the opening of the sulcus. If you see here in the top crown, we actually have a ridge lap. This yellow area is an area that sits on top of the tissues on a horizontal projection, and this is an area that is now difficult to clean. This area might predispose to plaque accumulation and bring plaque and biofilm very close to the opening of the sulcus, which is the critical area. Now, when the cervical margin does not coincide with the opening of the sulcus and we have this rut, then this is where we can expect inflammation to occur. On the other hand, if you look at the crown at the bottom, this is an emergence profile which is much more favorable. This is when we actually have the opening of the sulcus coinciding with the cervical margin and being fully accessible to oral hygiene. So here you can help your patient remove the biofilm on a daily basis and prevent the inflammation from occurring. So essentially what we see is that the cervical margin can be a very important parameter for success or failure on the long term. Now, why did we have to see this ridge lap here if everyone agrees that it's something not desirable and probably damaging? Well, if you look at the implant to the right, this is the configuration of the implant abutment and prosthesis, you will see two important problems. First of all, there is very little height. There is not enough space for the accommodation and the facilitation of the soft tissues, as we discussed before. There is not really this 3 to 4 millimeter zone when we move from the implant and the bone to the cervical margin. And why is that? Because in order to create aesthetics here, we have actually tried to create this ridge lap. If only the implant was placed deeper and a little bit more buccal, we could actually create a much more sustainable emergence profile and coinciding of the sulcus with the cervical margin and a much more sustainable restoration. So essentially the positioning of the implant is a key to making an emergence profile and a supracrestal complex which is compatible with long-term health. And these are some interesting configurations that I have got from the collection of one good friend of mine, Dr. Yanda, where you can see how difficult it is to maintain this prosthesis, because in order now to achieve feasible aesthetics into implants that were placed in a very wrong position, we have some prosthetic acrobatics, we have areas that are really blocking from cleaning on the sulcus, and we have a predisposition to inflammation. So the emergence profile now is becoming an important parameter. We see also emerging evidence of introducing to us basic concepts of how to design the emergence profile in order to have sustainable long-term outcomes. This study, which is very known lately from Katafuchi, has tried to identify emergence profile angles or emergence angles around prosthesis on bone level and tissue level implants and correlate them with clinical outcomes in terms of periimplantitis. Now, this has used what we call a tangent line, and that means a line which is touching a curve at a given point. And this, when we have concave and convex profiles, it's very subjective sometimes to define, so might have been a bit of discussion there. But when it comes to the bone level implants, at least, it was found that an emergence angle of more than 30 degrees combined with a convex profile correlates with periimplantitis significantly. So implants that actually had this wide emergence angle, especially when the profile was convex, were much more likely to develop periimplantitis in the future. That was now found for bone level implants. It was not found for tissue level implants, but when it comes to tissue level implants, the emergence profile was defined in this study starting from the platform, not from the bone crest. And this is a significant difference, because I do believe that the supracrestal complex starts from the bone crest. And when it comes to tissue level implants, we actually have the first couple of millimeters of our supracrestal complex and emergence profile as predetermined by the tissue color of the implant. Now, another important thing coming out through the lines of this observation was actually the placement depth. So when it comes again to bone level implants, the placement depth correlated significantly with this angle. So when the implant was placed at the crestal level, the angle was much wider than when it was placed subcrestal. So what does this mean? That means that actually depth of placement is sometimes essential in order to create a favorable emergence profile and prevent periimplantitis. If you place the implant too shallow, you might actually predispose to periimplantitis much more than if you place it in the correct depth in order to facilitate the soft tissues. And again, I remind you of the example of a shallow placed implant and how difficult it is to create a sustainable emergence profile in this case. Now, what does it mean 30 degrees? To help you visualize what is 30 degrees angle, I can give you this picture here. So these yellow triangles represent an emerging angle of 30 degrees. Whatever falls within this yellow area is probably in the favorable size. Whatever comes outside, it might be predisposing to trouble. Can you have reconstructions that come outside? Yes, of course you can. It's very common, especially when we have abutments that come very close to the implant shoulder and are quite wide, too low, close to the bone crest. So this type of abutments might take your emergence profile already from the beginning outside this safety zone, when essentially what we want to design is an emergence profile which is more narrow, stays within these yellow triangles, and gradually flares up to the cervical margin. Now, this is one of the great things that I do like with the newest line of implants in Straumann, the BLX. Most people will focus on the surgical aspects and how much it helps you gain primary stability in compromised bone. I would also emphasize on the prosthetic aspect, which is completely redesigned. So here we have temporary abutments which will come with different gingival height, as opposed to the previous line where we only had 1 millimeter gingival height. Now it can go up to 2.5 millimeters in gingival height, and also you can choose the final width of the platform. You can have 3.8 or 4.5. So essentially, already at the temporary abutment or the healing abutment, you can choose among 4 different designs, so that can facilitate the structure of your emergence profile much better and much more individualized. I think this is the direction we should be moving, allowing individualization rather than locking into very specific designs that might not be suitable for each case. So emergence profile, coming back, is something that we design, and we design for long-term success, because that might predispose to trouble or might establish the balance we want to see. And the emergence profile is very much depending on the position of the implant. So the positioning of the implant might be the first critical parameter that we have to discuss before we even move on forward with any other parameters of the emergence profile. The depth of placement, the width of the implant, and also the angle of placement might be really determinants that we cannot get over after the implant is placed, and from this point onwards compromise. So a very small checkpoint for the first part of our discussion. Proper emergence profile and cervical margin are essential for sustainable health of the periimplant tissues. This is our responsibility to design and to design individually. Height, angle, shape, contour, these are critical design parameters that cannot be left in chance when it comes to your supracrestal complex. And also, the ideal implant positioning is the prerequisite for a healthy and sustainable supracrestal complex. So start by designing the crown, move down and design the ideal supracrestal complex, and then the implant position will naturally emerge for you. For the next, let's discuss a little bit about the interfaces, the way that implant, abutment, and prosthesis are joining each other, and how these interfaces can impact the clinical outcomes. We know that gaps are really not something we appreciate or we want to see in any reconstruction. Also, nature doesn't like gaps, hates the vacuum. One of the common reasons for extracting teeth, vertical fractures, very difficult to deal with. How wide could it be a vertical fracture in order to create trouble? The trouble could be bacterial migration from the coronal side to the depths under the bone, destroying the periodontal ligament, or bacterial microleakage. How wide does it have to be? Well, not so wide. Studies that have analyzed vertical fractures on extracted teeth, they actually found the majority of these cracks to be between 10 and 60 micrometers, with some being between 70 and 170. So it is not really a big gap that can cause significant problem when we have cracked teeth. Already at 10 to 20 microns could be a detrimental effect. So have you thought about the gaps on the interfaces between the abutment and the implant, and how could they have detrimental effects on the tissues? Actually, this is also something that has been studied from very early on in implant dentistry. And I believe that one of the most common observations that we have for decades followed as a success criterion, the 1.5 millimeter bone loss in the first year, is actually having its root to specific implant configurations and specific kind of gaps. In the early days of implant dentistry, success and survival was actually much lower, and in the 80s we could also observe a lot of bone loss, marginal gradual bone loss. If you look at the success criteria that was acceptable in 1979, bone loss no greater than a third of the vertical height of the implant was deemed a success. You see, very big difference to what we think today. Now, at that stage, around the 80s, comes Adel and his group publishing a study showing that you can have actually very stable success, and survival was actually much lower, and in the 80s we could also observe a lot of bone loss, marginal gradual bone loss. If you look at the success criteria that was acceptable in 1979, bone loss no greater than a third of the vertical height of the implant was deemed a success. You see, very big difference to what we think today. Now, at that stage, around the 80s, comes Adel and his group publishing a study showing that you can have actually very stable long-term maintenance of the bone margin apart from a loss of 1.5 millimeters in the very first year in function. And that was envisioned as a natural bone response, a remodeling to the events of placement and loading, and it was utilized for decades as part of our set of success criteria. You could lose 1.5 millimeter of bone, marginal bone, in the very first year, and thereafter you should expect stability. But why would this be a natural anticipated phenomenon? Does it have to be? Or what caused this observation in this study? I think here we have to go back to see exactly what implant was used in this study, and that was the original Brånemark implants, which had an external hex connection. Now, if you look at this implant, it looks to many people today like a tissue level implant, but it was not a tissue level implant. It was meant to be placed flush to the bone, sometimes actually under the bone. It was also a very common norm at that time. Of course, what happens is that then you have this flat to flat connection where the prosthesis is sitting, this very important micro gap, which was not as stable in the external hex at that time, which is exactly at the bone level. Of course, the bone was always dragging itself away from this margin because of micro leakage or micro movement, and it would re-establish its biological position approximately at the bottom of this collar, which was 1.5 to 2 millimeters away. Thereafter, however, you would have very stable bone outcomes for the long term. This is something that we have observed also in long-term studies. In a recent study on osteoporotic patients where we prospectively followed Brånemark implants for 8 years, we would always see this bone aggressive remodeling at the time of loading before the first year, losing 1 to 2 millimeters on average, but thereafter, for the continuation of the 8 years, you would have very little bone loss. So if you want to see how all commercially available connections today behave under loading, I would recommend you to visit this website from the Goethe University in Frankfurt, which has some very interesting videos, and you can really see the differences between today's internal connections and the external connection or flat to flat that was used at that time in Brånemark implants. So today we would not see this bone remodeling anymore in the implants that we're using with this type of connections. In this study, for example, conducted in Bern on both tissue level and bone level Straumann implants, you could see that after 5 to 9 years, the bone margin on the tissue level implants was 0.3 millimeters below the tissue collar, while on the bone level implants was 0.4 millimeters below the implant shoulder. So essentially without any significant difference, but extremely stable long-term bone outcomes, including of course the very first year of any potential bone remodeling. Now, why do we have different connections here, and how the gaps in the interfaces today might be superior and predisposed to much better long-term outcomes? I think we can see some pictures through the scanning electron microscopy and understand a little bit better how the different components are merged together. So here we have two different configurations, the tissue level implant on the left, the bone level implant on the right. And if you look closer, we can see where the bone margin is meant to be. We have the interfaces. The first interface is the interface between the implant and the abutment, which is on the bone margin, on the bone level implant. On the tissue level implant, we actually have this interface much higher up on the tissues, 2 millimeters, 0.8 higher if you're using a standard implant, and also the interface between the abutment and the prosthesis at that level. Now, if we take this one by one, this is the interface of the abutment with the implant on the bone level size. And you see this actually interface is very tight. We can't even talk about a gap anymore because it is something that is usually 1, maybe 2 micrometers distance. It's a very tight connection, a very tight fit. And this to the left is with a gold abutment, to the right is with a vario base, and you can see how tight and how close you can hardly detect this margin when the material is the same in the scanning electron microscopy. That means that you don't really have any concerns with regards to micro leakage of bacterial products, and you also have no major concerns with micro movement. So I think this type of interface has nothing to do with the original flat-to-flat connection of the internal hex, and it can resolve much of the problems that we observed back at that time. Now, will it always work perfectly? There are two conditions, of course, here. First of all, you have to have a very tight connection. That means if screw loosening occurs, then yes, maybe you will have a problem. The second is that not all different abutments are born equal. Not all is the same. So this is a very tight fit, but it doesn't mean that every possible abutment and every configuration might also have the same tight fit. For example, here you see a compatible abutment. This is an abutment which is made by a third party to fit on a Straumann bone level implant from the ones that we have sliced, and you can see already on the coronal aspect of this junction there is really a misfit or an opening, and the fit is not as tight, but it can get even worse. Look at this one. This is another third-party abutment, and here there is actually a very, very wide gap. Now this abutment is sitting tight, is torqued with the proper torque into the implant connection, so clinically it will be stable at least in the time of placement, but how long will it stay like that and what will be the clinical implications, that is something to be seen. So I think we have to be very careful as well. There are configurations that work very predictably, but of course under different conditions we might still get problems. Now when it comes to the tissue level implant, we do not have the interface between the implant and the abutment close to the bone. We have it up higher on the tissue level, and that might be an advantage. At least it was a significant advantage back in the days when the other alternative was the bone level with external hex and flat to flat. But still we have this interface between the abutment, the implant and the crown that is quite an interesting configuration. Here you see a crown that is cemented on top of the abutment and polished extraorally. And although the crown is polished outside the mouth, what you see there is some tiny little bit of cement fill into this gap, this section between the crown and the actual abutment, which is very difficult to get rid of. Would this in the future present problems if this cement, which is now exposed into the sulcus, resolves or not? This is something to be seen. Another also important thing is there is a notch there between the abutment and the implant. The fit is very tight here. It's 1 to 2 micrometers again. So we're talking about a connection that is extremely stable, and it's also very solid. There is no risk of micro leakage, there is no risk of micro movement. But again, this notch here might be something that you don't want to have deep under the sulcus. So this area would probably work well if it is close to the opening of the sulcus, so if the tissue level is really used as a tissue level implant. It brings this interface very close to the tissue margin, which is accessible and cleanable. But if you sink the tissue level implant deep under the tissues, then this notch and this area might actually be very deep in the sulcus, might in early stages of mucositis get populated by biofilm, and might be difficult to clean or resolve afterwards. So clinically, you might see this interface, and as long as it stays epigingival or on the gingival margin, it can be sustainable and maintained without problems in the long term. And even greater gaps that have resulted from defective or deficient cementation, when they are on top or close to the gingival margin, they can actually stay healthy and maintain the tissues without problem because they are accessible to oral hygiene. But if you sink this interface deep in the tissues, then you might have difficulties in the future. And I think that was reflected in a very recent randomized clinical trial where tissue level implants with a deep sulcus or with a shallow sulcus were singled out. Experimental mucositis was induced, and then it was treated. And there it was observed that when the sulcus is deep, the experimental mucositis was more pronounced and less favorable conditions for treatment. Again, when the components are not favorable, there is very little that biology can do. And I can share with you this interesting case of an implant that was referred for the treatment of recession. Recession that occurred, an aesthetic complication within the first year of function in otherwise healthy tissues. Now, I knew this was a Straumann implant, so I was very puzzled when I saw the clinical picture. But then when I looked into the radiograph, I was even more surprised to see this very funny and unfamiliar configuration. Now, what is going on here was very difficult to understand until I realized that this was a very strange abutment used there. It was a third-party abutment which sits on top of the tissue level with an additional collar. Something like a platform switching on the tissue level, shall I say. But of course, the tissue level implant is meant to have the soft tissue interface for the first 3 millimeters. And here we have created a soft tissue interface of about 6 millimeters. Of course, there is very little one can anticipate in this type of configuration. And with an abutment of this type on an implant of this type, I think it is impossible to create a supracrestal complex that is actually sustainable and will be healthy in the long term. So for me, there was not really an issue of creating a soft tissue augmentation there. The issue was of changing the whole prosthesis to something that actually would be much more sustainable. But even better, if you can prevent the problem by actually using a correct implant and a correct abutment for the situation you're facing there. Now, gaps of bigger dimensions and bigger size deep under the tissues are very often connected with inflammation. In this case, we have a suppuration. There is a pus coming out of this fistle in the soft tissues, and it is not a surprise that the fistle is actually coming exactly where this big gap of the interface exists. So if you're having a gap that is deep into the tissues of that dimensions, a biological complication will be the next thing to expect, but there is no biological solution into that. You cannot disinfect even with magical features. The solution is restorative, and it means you have to redesign the supracrestal complex in such a way that is sustainable, and I think that is the only way to deal with these problems. So we are coming close to the end of the things I would like to bring up today, much of this being some raw thoughts that come to me when working and studying, and thoughts that I want to share and I want to expose, because the feedback and the ideas and the comments will help me to redefine them, to refine them, to take away things that do not match and maybe go deeper in the things that make sense. So finally, when it comes to the second part, I would like to mention that the interfaces are really important. The interfaces between the components, because they will have a favorable or a detrimental effect on the whole balance. So gaps are not desired, especially when they come deep within the supracrestal complex, and they can be detrimental in the long term. The gaps can act in different ways. They can be plaque retention points if biofilm migrates deep into the sulcus due to mucositis, let's say, or they can be channels for micro leakage if there is a connection with the oral environment. They can also indicate micro movement or misfit, which is also different types of problems. So the selection and the configuration and the design of the implant and abutment can be very critical for the long-term success. It is not something we should leave to chance or to our dental technician. Finally, the selection of the appropriate components, of the components that are reliable, they have a tested, documented long-term maintenance and fit. This is also critical. And closing up, I want to start from the very beginning, where we discussed in the beginning about problems. You see, when we see the problem or the complication, it might be already too late. There is many steps back that we should be aware of. So very often there is an origin, and the origin is that the implant was not placed in the perfect position, or the components that were used were not really proper. It is like you place your tent in the wrong spot. You might sleep a peaceful night, but the sun will come up in the morning, and then you realize that now it's difficult to resolve the situation. Now, why this malpositioning is a problem? It's because in order to create aesthetic outcomes or to make the prosthetic outcomes that you want, you're going to do some compromises. You might have to do a ridge lap, or you might have to make a compromised emergence profile. You might lock some misfit into the components in certain cases, and now this is not a problem, but it's a predisposition. Your patient will walk out of the chair and will be happy for some time, but now the chances of problem are increased. And you know, nature always sides with a hidden flaw. This is Murphy's law for implant dentistry. And predisposition will actually move into a risk, and the actual risk here will be the plaque accumulation, or on the technical side, gaps that will be created due to the misfit, framework tension, and there will be communication between them. The gaps might lead to even more plaque accumulation. So that is now the true risk factor, and if you get to the point that you have this true risk factor, sooner or later you will see the complications. Complications can be, as we said, on the biological side, or complications can also be on the technical side, and by the time you observe them, it might be already too late to address the origins. So I would emphasize to focus on the origins, to design for long-lasting success, to understand the parameters that help you design for long-lasting success, and then move on from there. So remember, periodontal tissues are physiological. They have evolved through an evolution of millions of years to serve a specific purpose, and they do it very well. They can be stable in health and contain the disease progression very efficiently. Peri-implant tissues are not physiological in the sense that they do not really exist in your body. It's a repair tissue. It is created by your body in response to a trauma, which was the implant placement. And they actually serve their purpose also very well. They can be very stable in health, but once inflammation or disease kicks in, the response is always compromised. So let's make sure that we create the conditions to have the tissue stable in health. And with that, I would like to thank you very much for staying that long to this presentation. I would like to thank you for your interest, and I want to thank again Straumann Live for giving me the opportunity to expose some of my thoughts to such a wide global audience. I will be looking forward to any feedback, comments, or suggestions to where things would be more interesting to pursue, or things that might be actually not really right or not to the way that everyone would like to see them. And with that, I would like to thank you for staying that late, and again thank the organizers for the opportunity to share some of my thoughts with such a global audience. Please and with that, I would like to thank you for staying to that end of the presentation, and I would like to thank the organizers once again for the opportunity to share some of my thoughts with a global audience. Please stay in touch. Please feel free to send me any thoughts, comments, ideas, suggestions, anything that went well, anything that went wrong, anything you agree or disagree, and we can continue this debate on social media, email. Unfortunately, for the next near future, we might not meet in person that much, but I do hope eventually the world will open up again and we will continue not only discussing online, but meeting and interacting face to face. So thank you all very much, and I hope that there will be a continuation and we will continue this discussion online or offline in the future. Thank you. Okay, good. Thank you very much. Thank you for the comments and the questions. I see a pattern here, and maybe I would like to elaborate a little bit on that. It seems that the questions tend to the direction of when to use bone level, when to use tissue level. Do we use one or the other? Do we use them both? Do we use only one? And I have to say that I have matured into this question myself as well, because I started using the tissue level many years ago. I have been using bone level at all times, but I mean the balance between the two has been shifting as we advance and as we come closer to the day-to-day. I do place a lot of tissue level, and it's a very darling implant, if I would say, of all periodontists. I think that it still has a purpose, it still has a role to fulfill, but you have to stick to the actual indication, and the indication is in the name. Tissue level is meant to be placed as a tissue level. That means the prosthetic platform, the collar, should be up on the tissues. If by all means there is a need to sink it, to tilt it, or to somehow change it from being a tissue level, I think then probably you're better off using a bone level. So if I can place a tissue level, usually in the posterior maxilla or mandible, and on a flat bone and flat soft tissue configurations, that means that the collar is going to be very close to the soft tissue margin. I think you have a very good advantage with this implant. On the other hand, if you need to sink it under the bone for any reason, because you don't have enough soft tissue height, because the bone is uneven or so, or because you need to tilt it, I think this is when it starts to get into situations where I would prefer a bone level. And the way I would prefer a bone level is because you can really sink it and you can design the emergence profile with much more freedom. At the same time, the tissue level is locking your choices. The emergence profile starts at the bone. And the first couple of millimeters, when they are locked into the collar, that limits your choices, and in some cases might work well. In other cases, might be better off to use a platform switching implant with your own individualized emergence profile. So yes, I do believe tissue level have a very good purpose today, but I would use them mainly on indications that have to do with posterior sides, flat bone, and when I can secure that the collar will be not too deep into the tissues. Now, does it make a difference if you're going to use tissue level or bone level with regards to periodontitis treated patients and periimplantitis risk? I think that this is not really the determinant. For me, the real determinant is how well you can design the emergence profile, how well you can avoid a ridge lap, and that you can do in actually both implants. And it's a design feature, is not really locked because of the type of the implant. Now, if you have screw loosening, it might be worse on a bone level. And I think this is the case because the interface between the implant and the abutment comes very close to the bone. Normally, it is very tight. Under ideal conditions, it will stay tight, but if for any reason you have a loosening, then it might be causing more damage than if it happens on the tissue level, which is really high up and away from the bone. So yes, there might be things to consider, but that might not necessarily make a decision as one being favorable versus the other. Lately, I have heard people mentioning that in the study of Katafuchi, for example, which I discussed before, there was less periimplantitis when the tissue level implants were used. And this might be true partly because the data that they present, the numbers they present, they show actually lower prevalence of periimplantitis on the tissue level implants. But of course, the authors very carefully, they avoid the comparison, so they don't do any comparative statistics. They don't try to compare the two things. And I think that was very wise, because there is a big difference in the sample used there. If you look carefully at the sample, all the tissue level implants they used are Straumann, but the bone level implants are actually very different. Many of them are flat to flat. There is some Bronnemark, there is some Biomet there. So many of them are actually external hex possibly, or flat connections. So I think it would be definitely not a very easy comparison. As of today, I don't think I have seen convincing evidence that there is any difference in the prevalence of perimplantitis when you use bone level versus tissue level. I think that both can actually perform very well once the indications are followed. And for me, the indication is just design the right profile, make sure that you keep the tissues where they should be and the gaps where they should be. And yeah, I hope this will help at least with this part of the questions. Now, oh, I see the questions multiplied very quickly. Oh, give me a second to go through. And now there is also a question about the vario base versus the gold abutment in terms of precision of fit. And here I think I should say that having sliced both of them in certain environments, I think that they fit very well, both of them. We couldn't see any difference in the fit of the components. Now, the vario base is an abutment that is somehow predetermined. Now, it comes in many different tissue heights, so you can actually, to a certain extent, decide much about the emergence profile. The gold abutment, it was made for casting, so you could really design your own abutment. So it was for a long period my favorite abutment, because I could actually create the emergence profile by casting the way I wanted. While now with the vario base, the first couple of millimeters or 3 millimeters, depending on the height that you choose, is locked into the abutment gingival height. But still, I think now the variety of configurations we have with the titanium vario base is actually really good. It can accommodate a lot of freedom in choosing the emergence profile. But when it comes to fit, I think that at least in the lab, in the slicing and scanning electron microscopy, we couldn't really see any differences. There was both very good fit. Now, do I have a standard implant in my portfolio in comparison versus standard plus? That comes back to the tissue level. Yes, I used to place a lot of standard plus in the past. I now stick to the standard. You see, the standard plus was an intermediate introduction when the aesthetic demands were increasing, and the color of the standard implant was quite high, was making people nervous that it might really be exposed with a little bit of recession, and that would be an aesthetic problem. So the standard plus was introduced as an aesthetic cases alternative for the standard implant. Apparently, very shortly after that, the bone level came. So now the true aesthetic alternative is the bone level. I think that the standard plus is something I would not use really often. The standard plus has a 1.8 soft tissue collar. Now 1.8, if you anticipate the soft tissue to be established around an 1.8, probably then we are compromised. If we accept that we need 3 to 4 millimeters sometimes, maybe this is a bit too little. So I would prefer to use the standard in posterior cases with flat bone when I can create a good emergence profile. Or if not, then go for the bone level. The standard plus, in my mind, in my hands, is not a very common option. Now, of course, this is a very individual opinion here. I don't think that I have any evidence to back it with. It's just a common sense consequence from the discussions that we have had so far. I'm refreshing the questions again. And does the tissue level implant need to be covered with gamete placement, or you could have a healing abutment placed in a single stage procedure? Yes, I would go for a transmucosal healing in almost every procedure. I mean, the only way or the only reason that I would have to submerge an implant today would be if I'm not confident about the stability. If the implant is slightly spinning and there is no other way to do, I don't really feel that the stability is up to the level I want it. And I mean that I can spin it, not relocate it in and out, but at least with a finger pressure, then I would today even also submerge. But I do believe that the transmucosal healing is an advantage in many ways, not only because it makes things easier, you don't have to do a second stage, but also because I'm using the healing abutment to support the soft tissues. If you submerge the implant and you have thin soft tissues, your soft tissues will remain thin. And then when you open up again, you will have to do some sort of modification or manipulation in order to thicken up and give the height that you want. If you put a healing abutment, you can suture on top of the healing abutment, and that will keep your tissue level height. So even with thin tissues, you can actually gain some tissue height using a healing abutment. You can gain some millimeters on each side, buccal and palatal, which you can use for the height. Again, this is now a very technical thing. I would not be able to back it with any evidence, and it's something that I would rather show than explain. But I believe that I don't really see any indications very rarely today to make an implant transmucosal, submerged. I think transmucosal is my norm. And finally, I think comment on a conical connection versus the flat to flat internal connection. I believe today, from what I have seen, from what I have come to realize, that a tapered connection is always better to a flat to flat. It brings you better fit, it brings you tighter fit, it brings you closer gaps, it responds better to micromobility as well. So I would today not see much purpose for flat to flat connections. Again, this is a very personal view. I know a lot of prosthodontists who would argue about versatility, about the ability to restore, about the ability to correct maybe problems in the placement with this kind of connections. So it is a little bit of a technical question. Probably in my own understanding, I would always go for internal and conical connections. And I think that today should be more or less a significant advantage. And with that, I think that the major topics have been more or less discussed. I do not see any other coming out. Oh, yes, I see. The shape of the abutment towards concave and convex. Well, I would also go for very thin abutments, at least at the base, at least where they emerge from the implant, because this will preserve space for the soft tissues. And I think it is something very important. Try to preserve as much possible space to accommodate the soft tissues there. So I believe that a concave shape, which starts from a very narrow and flares gradually up to the cervical profile, would be the ideal. Now, the challenge here is to avoid the ridge lap, and it's not always possible. Very often we have to restore teeth that have very wide dimensions, maybe on the mesiodistal, sometimes not on the buccolingual, but on the mesiodistal, and there is little one can do. But I would at least try to design it in such a way that I avoid any kind of ridge lap, allow the sulcus to be open for oral hygiene. And I think that using a concave emergence profile, starting with a thin base and flaring up gradually, that would be probably the best way. If you are to introduce a compromise, at least you can make a well-informed decision when and where to introduce this compromise and how you can at least try to make it cleanable. Sometimes we can make a ridge lap cleanable by making it in such a way that the floss can really come underneath like an ovate pontic. If you create a concavity of the ridge lap, this is the most difficult to clean. If, on the other hand, you make it like an ovate pontic, sometimes the patient can use the floss and keep it clean. Again, very technical. Unfortunately, not much evidence to back it with. And with that, I think that everything is more or less covered. So I don't see much more different emerging themes. So thank you all very much. And what about the operators? Are we completed now, or you see any more tasks coming? Let me see, because maybe I need to refresh again. So, okay, yes, I see some more questions popping up. What's the minimal dimension of supracrestal soft tissue to ensure stable bone level around the implant? And I think this is now a question which is also being addressed. If we're talking about purely the vertical height, so we're not talking about thickness, because sometimes this is confused here. I hear many people who say about tissue thickness, but they actually mean the horizontal thickness of the tissue, which is totally different. If we're talking about a vertical component of soft tissues, my understanding today would be that 3 millimeters would be what I'm aiming for. And that would be the same if you're working on the posterior, on the anterior. A minimum of 3 would be enough to secure in most cases. Again, it's most cases, not everything, because I don't think there is a magic number. We humans are very different. Some people have a big nose, some people have a small and cute nose, and it's all physiological. So why should the soft tissue differ to that? There might be areas, there might be sites, there might be people with maybe thicker or higher or different type of attachment there. There might be others with thinner. But I think that if you stick on this 3 millimeter as a minimum, you're covered in most of the cases. Now, how do you achieve these 3 millimeters of vertical height? Either you have already 3 millimeters thick tissues, or if you don't have this, then probably I would use the healing abutment to manipulate the tissues to suture on a higher level and create this space. Other alternatives have been suggested to do connective tissue grafts. I find this a little bit unnecessary, or I find it in most cases a bit too complex, that you can achieve what you need with simpler ways. What I would avoid is to sink tissue level implants, for example, to put them deeper in the bone because I don't have enough soft tissue thickness. Or if you're working with bone level implants, then you have more alternatives. You can also place them subcrestally and somehow modify the emergence profile with the placement positioning. But essentially, I would aim today for 3 millimeters of soft tissue height. If I have them, I think I'm more or less fine. Now, if you're in the aesthetic zone, sometimes you might need a little bit more. If you're doing immediate implants, for example, in an aesthetic zone with immediate temporary crowns, then you might also need some deeper placement and you end up having higher soft tissue margins. So it is a little bit individual. You have to be able to go case by case. But I would consider myself safe if 3 millimeters is established. And with other questions, not directly related, what is my favorite graft material? Difficult to say because it depends on the indication. I think that the choice of the graft material has to do with what you are about to graft, for what purpose. Are you doing a contour augmentation where you don't expect necessarily quality bone for osseointegration, but you want to create stable tissue profiles? Or are you doing actually an augmentation of the bone for future implant placement where you actually really need to have quality bone? Eventually, I think there is a lot of different indications, different materials. Hopefully in a future lecture, we can discuss a little bit more on that. So I think that that would be most of the questions I can see right now. If you see something different coming up. Would you recommend BLX over the older implant? Well, I don't think that there is any. BLX has a specific spectrum of indications, has a lot of new features, so I think it could perform very well in specific cases where previous series of implants might have been marginal. So you can definitely use it in a wider range of indications. What I do like, as I mentioned, is that the prosthetic series of the BLX now is significantly improved. So the healing abutments, the temporary abutments in particular, are actually a significant improvement over the previous temporary abutments we had with the BLT and with the bone level. And especially when it comes to immediate implants, where you have to place the implant significantly deeper than the bone margin, the older temporary abutment was very difficult to sit in some cases, and you had to either modify the abutment by trimming it or to modify the bone. And I think BLX has addressed this problem. Now it comes with a much better choice and much more versatility. So you can customize the drilling protocol to correspond to the bone that you're drilling. You can customize the restorative selection of components to a higher extent. It is, I think, evolved, and it gives you more choice. At the same time, you have to be able to know why you have this choice. So I think it takes a little bit more experienced users to understand how this versatility can help you in the individual cases. And last refresh, let's see if there is something coming. No, I think that was pretty much all. I don't know, have I missed something, do you think? Thank you all very much for staying that late. I wish you a happy weekend all over the world, and I hope soon we will be able to talk in person and meet face to face and continue these discussions on a friendly basis, so we can also go for a glass of beer or a glass of wine right after. Thank you very much. Thank you. Bye.